Awesome. All right, everybody, we are live, and we were just going over the pronunciation of Eliseo's name. So I am live. Oh, hold on, we're fetching the stream. Let me just make sure we're good to go so that everybody can see us both. It looks like we are. Yep, there we are. Good. Okay, so we are live with Eliseo. Eliseo, he just helped me with the pronunciation. Help me again.
Tahan Langit.
All right, Tahan Langit. So Eliseo, it has a really, really interesting story. I know there were a lot of you that were really curious to hear more about what he does and ask maybe some questions while we have him live. But I thought we'd maybe just jump right in and have him tell us a little bit about what it is that he does and how he helps older adults and their families.
Thanks, Allie. My name is Eliseo. I am an ER nurse. Actually, now I'm an ER case manager about 5 years ago. How I got involved in my work about 5 years ago because there's a lot of things going on. There's a lot of things converging. My father-in-law had dementia. We had to go through that. We had to learn how to privately pay for his care, about $100,000 per year out of pocket. At that time, that was like 2008, 2010. And you know what happened? We were hit with a sequence of returns that, his 401k and then his real estate went down, and how do you pay for that stuff? So all that, I was having a sense of burnout after 20 years in nursing, and I just couldn't understand what was going on in the emergency department. We usually see about 150 to 200 patients a day, and we're just trying to figure out what the heck is going on. So in our ER, we had case managers, and they seemed to know what was going on. And what they did to help me direct to figure out what was going on was take a look at the senior care directory, where you look at some of the costs of assisted living, nursing home, dementia care. Sometimes it's up to $300 a day, which is equivalent to, let's say a nurse's salary for the whole year. And I'm like, how the heck do you figure that out?
Yeah.
So I decided to address that burnout. I switched to case management. Got my board certification in case management. And at the same time, I need to learn about insurance. So a month after I got my board certification in case management, I got my life and health insurance license. I said, what the heck? I might as well learn insurance, right? Because that's what everybody was asking about, was Medicare. And right after that, worked in still as a discharge planner, case management and utilization review in the emergency department. To my left is usually a social worker. Behind me is the pharmacist who does the medication reconciliation. And then you still feel that surge of people coming in their 80s and 90s, and also just in general, the people coming into the emergency department. So finally, something quantifiable, a research from University of Maryland came out that, half of the hospital-associated care comes from, is practiced in the emergency department. And I'm like, oh, there you go. So now I'm doing concurrent review. I'm doing discharge planning. I'm talking to people about observation versus inpatient, and they're demanding how to pay for it. Is this covered? And I'm like, okay, in terms of, and because of my insurance license and also board certification, I was able to tell them, that yes, this is covered.
Right.
No, this is covered. If you have a Medicare Advantage, I don't know. There's so
Yeah.
many iterations, there's so many variations in it that I tell them to go look at your thick booklet of how to what is covered, because essentially that Medicare or CMS pays that company to take care of you, and so they make their own rules, and those rules vary. So when they come in with symptoms of stroke or mini stroke, and we can't really figure out what's going on. With we know that those TIA or mini stroke symptoms, you have a 40% chance of getting the big one. So we have to admit you under observation, but and so people are afraid of that. They listen to the ARP studies and they're like, oh, never be admitted under observation. Well, we can't make stuff up, but we still need to safely take care of you and do more testing, diagnostic testing. The sequence of that is you have to be admitted in order to get the MRI. And I've seen some where the CAT scans were normal. They were not actively bleeding, but when they do the MRI in the hospital, then they find like a pontine bleed or anything like that signifies that they had a stroke deep down within their brain. So we can't send you home because until we figure that out. So that observation issue is now a law in Pennsylvania. I don't know where your followers are, but we have to let you know. It's a Medicare observation form that you have to sign, that you were told when you're admitted that you're observation status. Okay, so that is a law now. They have to be notified because we down the road they don't want them to accuse the hospital of not letting them know.
Right.
Because again, observation. If you have the original Medicare with a supplement, that's usually covered. If you have the Medicare Advantage, that's where you're kind of limbo. Okay.
Right.
Then after that, the process through the emergency department, you get admitted, and usually, if I'm just going to go with the Medicare with a supplement, they treat you, and they need about 3 consecutive inpatient days to transition you to the community short-term rehab place, which will then be covered by Medicare. But if you don't have that, then there's some out-of-pocket costs. So we have to address all that. So aside from all that stuff, I went into all the tangents of how you go to the emergency department, but aside from that study that we saw, because I was in the emergency department, a lot of my coworkers came about and they said, hey, you're the Medicare guy. You know Medicare? I'm about to retire. So a lot of the housekeepers came, a lot of the CNAs came. They before retirement, they wanted to check to see, if they were covered, or what else they can do, what other issues that they need to do in retirement. So I helped them out. I tweaked some of their 401ks, kind of told them how to help them out. They set up their long-term care insurance if they had some. And then I dabbled in all these other things, like help my mother-in-law save $65 per month by putting them in a different plan, or move them. Then I just volunteered for some of my neighbors to help them with their long-term care claims, because they make you jump through a lot of hoops in order to get those 280Ls down. So there's one that was helping that she was trying to get her long-term care. She had the Cadillac plan. long-term care. It took her 4 years to try to figure out how to do that, and it took me 6 months, even with my help,
Yeah.
to get her claim. But you know what? She got it done. She's covered, unlimited.
Wow.
Um,
Yeah,
yeah,
that's the
that's one of
Cadillac.
the Cadillac plan, absolutely. And then I helped her husband, who unfortunately had to go to assisted living, to do that claim as well. And the recent one that I did was, even with my help, and her sister was helping her out. She was pulling her hair out. It took her, 6 months. Finally, she said, "Okay, help me out." And it even took me 2 months. And um, the technicality of it was that the nursing home, or the staff there, didn't know which code to put in the minimum data sheet, the MDS,
Right.
right? And so it just needed tweaking. You need to put 01 or 02 instead of, so
Oh my
anyway, that helped
gosh.
it. And you wouldn't know that unless you um, knew how to fill one of those out.
Right.
Um, so um, all that stuff, right? It
Wow.
came about. It gets complicated, but I started volunteering, um, got licensed, got board certified. I'm still doing it
Mhm.
every single day. It's
Mhm.
like Groundhog's Day, right? You're helping the same issues over and over and over again.
Mhm.
But what I do in the emergency department is that it's, they don't have a return on investment in really what I do.
Mhm.
So some of them don't have them in their emergency department, like me.
Right.
So, but what I see is that we need to do more, or I need to be more visible out in the community, because once you come into the emergency department, it's a bit too late. I'd
Right.
rather have, let's say, seminars out there and have question and answers, because it's very complicated.
Yeah.
Um, so I reach out to a lot of the power of attorneys,
Mhm.
the caregivers, the family members. I reach out to community resources like you,
Yeah. Yeah.
to, if I'm not able to address that, if I'm stuck in the hospital, I send them out to you. I I vetted you, I vetted other community partners,
Mhm.
that the handoff, you're going to take good care of them, and
Right.
that's how we got introduced, right?
Right. So how do we clone you? Because it sounds like you're such a great resource for your patients and their families. I wish that they did have somebody like you at every ER, or, it's a shame that they don't. But definitely your past experiences led you to being able to be that great resource, it sounds like.
Thank you. But I think that this is the new reality for the nurses, in order
Mm.
to um, pivot in this new
Oh,
economy, with AI and machine learning,
yeah.
and also the claims data from all of the electronic health records. You're able to
Huh.
uh, be more valuable out in the community. And I think
Right.
that is really what's going to be happening in the next 5 to 10 years, is that um, experienced nurses, in order to differentiate themselves and also be more valuable, um, they need to be board certified in case management, as well as know all the insurance issues and work with other professionals, in order to really take care of the patient and the community. Because um, there is a lot of talk that, those big buildings, the hospitals, are
Mhm.
just going to be operating rooms and intensive care units, and everything else will be out in the community.
Huh.
um, you see that now with all the mergers and acquisitions, that they're gobbling up all these urgent cares because they
Mm-hmm.
want them to see them. And also there's more value-based programs out there because it's, you know, more cost effective for the insurance companies to treat you out at home and out in the community than those big buildings, right? So
Huh.
you need, you know, so nurses need to step it up and be more valuable to the client instead of feeling that they are underappreciated and
Right.
burning out at the
That's
hospital.
interesting.
Because you
That's
know
really
how we're
interesting.
getting, you know how they translate our services in the hospital? They bundle up in the room rate.
Right. Right. Yeah.
And so
Yeah.
if you really wanted to show your expertise as a nurse, you need to go out and try to market yourself out in the community and see if you're really that much more valuable. And I feel that we are.
Yeah.
You
I
know,
think
I'm
you've
kind of
got it.
showing that,
Yeah.
right?
So that might lead me to kind of like my next question. So what's something that you feel, and I like to ask a lot of people this, what's something that you feel like is maybe like a misconception about what you do or people in your profession do?
Um, there's a lot of families, or everyone who has taken care of a challenging family member thinks that they can now make a business out of taking care of
Yeah.
families out in the community, but really they're doing a disservice to that person if they're not properly trained, because there's a lot of liability issues with certain advice. With
Mm-hmm.
certain advice, I have to be licensed to to talk about Medicare and also switch them um, and guide them through whether it's original Medicare or Medicare Advantage or other issues, right?
Gotcha.
I have to be licensed in order to discuss medical issues, and I have to have community partners with physicians or primary care physicians to advise their um, uh, patients, right?
Mhm.
So if they if you know, if those family members or ones who want to buy a franchise or something like that, that they want to follow, you know, they want to give those advice, they have a lot of liability
Mhm.
along with that, and I want them to be careful. So, and
Mhm.
also for the nurses, if they think that they're they want to step up their you know, their skills out in the community, they want to market
Yeah.
themselves out in the community, they need to know all the community resources
Mhm.
and have to practice, because you you're an expert within the hospital system, but when you're out in the community, you have to work with, you know, the uh, elder care attorneys, the financial
Yeah.
advisors, you know, services like you, the concierge services like yours, because I can't do it all. The nurses
Right.
can't do it. Although,
Right.
you know, they seem that they can, you know, we're super
Yeah.
nurses, but we can't. I can't.
Yeah.
We're only limited by time and resources as well. So.
So does that kind of play into like where you see nursing going? Like if you were to paint a picture of where you expect that your career or maybe some of your colleagues' careers will be in 5 to 10 years, where do you kind of see the next stage? Like what's something you're excited for in the industry?
Uh, I think that again, with all the artificial intelligence, machine
Yeah.
learning, the claims data from you know, the electronic health records, as well as those claims data from, let's say, point and click care. They can gather all that evidence-based trends, and you're able to give better consultations to the patients and the family members who are really looking to optimize, um, you know, their care
Yeah.
for the families. So um, also the main thing that I see is to really optimize Medicare, right? One of the things that I focus on is I made up something like, say, 100, the Medicare optimization for the 100, 60, and 100, right?
Oh, okay.
So Medicare, in order to get another 100 days of care, you have to not use it for 60 days. And what resources do you have in those 60 days will determine whether or not you can have 100 days. So what's going on now with the 78 million baby boomers they're going to have to address the end of life care and also the palliative care. And that's where they have to learn about they have to take a course, the End of Life Nursing Education Consortium,
Okay.
where the nurses and all the healthcare caregivers are trained how to talk about palliative care. That's the bridge between hospice. And so they need more training because we have to be a little bit more forceful in that situation. The end of life conversation, because the silver tsunami is cresting with end of life conversations. And when they come to the emergency department, I have to have the conversation. Let's say if it's 42%, or let's say half of the 78 million, right? I have to discuss that, and time is of the essence. And you have to have those very, very hard conversations ahead of time, because when you come to the emergency department, we need to know now, right? And so that's what the nurses have to address. And I would encourage them to take that course to sharpen their skills in order to address that. We don't want to we have to be empathetic in having that discussion, and it's not a short conversation. You see what I'm saying?
Oh yeah,
right?
absolutely.
Yeah.
That's amazing advice for them.
Yeah, that's what I would encourage the nurses. And that's just, again, adds to your professionalism and to, your value to the community to have the discussion, right? So that's what I see.
Okay. How about for the families? Like, if you could only give one piece of advice to the families that you serve now or the ones that you may serve in the future, what would that piece of advice be?
Actually, there's 3 things that I would like.
Okay, I'll give you 3. Yeah.
Meaning that, no, because again, the number one thing is then work on the advanced care planning side of it. Address your durable power of attorney. You really have to have the honest end of life conversations with their family. And the second thing is learn how to fund your long-term care, right? Because you don't want to limit your choices, and everyone is affected. The caregivers, your family members, is affected in the continuum of your care. And part of that funding is, again, we talk about the Medicare optimization, the 100, 60, 100, and have another conversation with your financial advisors, because they may need to have the nursing insight with your plans. Right. And stress test it for dementia, because there's no cure for that. If your financial advisor says, oh, you can self-insure that, no. Right. I'm seeing it every day in the emergency department. It's not a movie. It's actually like live streaming, and I could tell you exactly what's going on. You could call me. I always tell them, call me on my cell phone, text me, right? Call me at 610-209-9696, right? I would put it out there because I can just have that conversation and kind of steer you and talk to you about what other resources you may want to be able to address, right?
Mhm.
So yeah, talk to your financial advisors because they're trusted by them.
Right.
And also when you're the financial advisors, those are the other people that are coming to me to ask my opinion, because not only do that they're trusted, right, for their clients, it makes them more it differentiates them from the other practices, and that's what all those financial advisors are looking for anyway, to treat their trusted clients. Their clients trust them,
Right.
and they want to know, they want to do the best thing for their clients. So I'm seeing a lot of those financial advisors calling me as well and asking me for advice, or what other issues do I need to address per
Mhm.
your nursing insights. And I've also in the community elder care attorneys that are
Mhm.
that I'm working with, and they seek me out. So
Yeah. Okay, great. So you mentioned a little bit, but if people wanted to get a hold of you, what's the best way for them to reach you?
the main thing is just call me on my cell phone.
Okay. And tell
it
us that number one more time.
it is 610-209-9696.
Okay, perfect.
Again,
And I'll put it in the notes here too.
well,
And
and then or with that phone, you just go ahead and text me. Text
oh,
me
cool.
your first and last name, and where you learned, where you found me,
Uh-huh.
right? If they found me here, that way I can put them in on my phone and program them. Because if I get like numbers that I haven't programmed in, they're robocalls, right? Or
Right.
telemarketing, right?
Mhm.
And it's you just put me in your back pocket, because
Yeah,
I
that's
don't
great.
I don't I don't you met me through a person who knew me, from one person to another. I don't
How it
advertise,
works.
right?
Mhm. Yep.
and 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 but I do have a valuable service. At
Oh,
least
for
just give me
sure.
a call. We'll have that conversation, and I'll help you out free of charge.
Awesome. Well, I am so, so thrilled to be able to share that with everybody in my network. And I hope if you're listening now or if you're listening later, you feel compelled, please give him a call or share it with somebody you know that might want to. What's one thing that you can leave us with, or any last thoughts that you might have?
Um, Everyone should be kind to everyone, because you never know what they're going through. And it's the older I get, the smaller the world is. So
Yeah.
you are, somebody who knows somebody,
Yeah.
and you just better be kind to them.
Yeah. Oh, wonderful, wonderful, wonderful. Awesome. Well, thank you so, so much for everything you shared with us today. Again, anybody that wants to reach him, feel free. I'll leave his contact number in the notes here so you can give him a text anytime. And we'll look forward to talking again soon.
Thanks, Allie.
You bet. Have a good day. Bye.